Good afternoon, everyone, and thank you so much for joining in. I'm Dr. Kim Newell-Green, and as usual, I'll be the moderator for today's virtual Grand Rounds, which is sponsored by California Health and Human Services and the California Medical Association. Today, our Grand Rounds is entitled Pediatric COVID and Vaccines and Variants Overseas. Next slide, please. I just want you to take a quick look at the speaker's disclosures. Next slide, please. And here's our agenda today, which we'll talk about in a moment. Next slide, please. And just a reminder that CME is being provided today. You'll be sent a survey after the completion of the webinar. If you attest your attendance, then we will send out your certificates in about a week. Next slide, please. So we entered this spring with our lowest COVID case rates in 2 years, and we began to roll back various recommendations and requirements on masking and gathering. I think all of us have been cautiously hoping that this is marked a new phase of the pandemic. Now, some of us are watching in trepidation as a new variant takes hold across the globe and causes cases to increase in various parts of the world, including Europe and Asia. How will this variant impact our management of the pandemic and our exposure to COVID-19 at home? What will the summer look like? We are so excited, as always, to have our regular guest, Dr. Erica Pan, to guide us through the epidemiology here in California and discuss the state's efforts to prevent morbidity and mortality as we continue to live with this wily virus. As we follow the evolution of COVID-19, we're always interested in the latest news on vaccines as we hope to present strong immunity to our foe. There have been successes, but also pauses in the development of vaccines for the pediatric age group specifically. And to get us up to speed on this progress, we are thrilled to host Dr. Mark Sawyer, a pediatric infectious disease expert. And Dr. Sawyer will review COVID-19 in children, help us to understand the current state of pediatric vaccines, and offer advice on methods to communicate with families regarding vaccinating their children. As always, we'll start our session with Dr. Erica Pan, the California State epidemiologist. Thanks again for being here, Erica.
Great, thanks so much for having me, Kim. And I will launch right in. So the next slide. So again, I'm going to cover just a little bit of an update on what's going on with our epidemiology here in California. As Kim mentioned, I know everyone's wanting to hear all about BA2 and actually some of these other new variants, so I can give you some perspective on that. A couple updates on guidance. I know there's still a lot of questions about therapeutics. I wanted to cover a little bit about that briefly and hopefully tee up Dr. Sawyer quite well with a little bit about our upcoming family and kids vaccine campaign, which he's going to equip you with some great information to support. Next slide. So this is the epidemic curve that I show you, I think, every month, and just kind of the progress. And just to quickly highlight again what the different colors mean. The blue line is cases. So you can see we had that huge Omicron surge peak, and we've continued to come down nicely. And as Kim actually mentioned, we are now at levels pretty close to last summer when we were in between we had our lull after our reopening and pre-Delta surge. Similarly with hospitalizations, which are the red, the orange curve are hospitalizations. Those are at a nice nadir as well. They are almost as low as last summer, getting close to 1,000 people in the hospital in the moment. And also very importantly, less than 5% statewide of people in the hospital have COVID. And at the peak of things, for example, in the Omicron surge, we're seeing sometimes more than a fifth of patients in the hospital with COVID. So that's also a very good sign. And new admissions as well are at the lowest we've seen since last summer. And ICU as well. We are still seeing our lagging indicator of deaths, but those seem to be gradually improving as well. And test positivity has been stable at around 1.5, 1.6% for the last couple weeks or so. Next slide. This is another nice way, actually, again, to highlight what I mentioned about hospitals being decompressed after the Omicron surge. So you can see by region, the lower right-hand panel is California. The top lines are overall hospital census, so not just COVID, but you can see as COVID peaks, it pushes the overall census up. So during the Omicron surge, we were at, again, over 20% above our baseline of total hospital census, and that was when the lower solid curve was over 20% of all patients in the hospital were COVID, and again, nicely decompressing. Next slide. So what is going on with variants? So CDC has been doing some modeling based on overall data that we see globally around BA2, which is a subvariant of Omicron. There's always a lag in this data as well, but as of March 26th, they were projecting that about 60% of our isolates in California were this BA2 subvariant. Our modeling team has a little bit more recent data and projections that it's probably about 80%. This is certainly varying by region. We estimate for example, the Bay Area, it's probably 100% BA2 now. So it's been gradually increasing over the last several weeks, and we expect it to be dominant within the next couple of weeks as far as probably all isolates will be BA2 very soon. Next slide. So what does that mean? And we've been looking very closely and monitoring what's happening. In this slide, we're comparing to other parts of the country. So New York and New England are a few days ahead of us, probably about 10 days as far as when they've started to seeing their increases in BA2. And you can see the upper right-hand graph here shows you the proportion of sequences of BA2. So it is absolutely increasing in all of these different areas. California is the black line, and then you can see again some of the New England, New York areas have higher proportions than us. And so that's the proportion, again, of what they're seeing as far as their SARS-CoV-2 virus and dominance there. But then if you look at the lower right-hand panel, you can see their case rates. They have actually stayed low. They are in some places plateauing low, so some slowing in decreases. Some of them are maybe starting to increase a little bit, but still actually relatively low if you look at them coming off of that Omicron surge. And again, mentioned that we're thinking about 80% here in California at least are BA2 now. And you can see again that our case rates have continued to decrease despite the increases in BA2. Next slide. So I apologize, this is a very busy slide and I'm certainly not going to walk you through all of it. But the theme here, a couple themes I just want to point out. You can see around the world, the gray line is, again, the proportion of BA2 that these different countries are seeing. And the timeline here is days since that country saw at least 10% of what they were sequencing as BA2. And you can see across the globe, it's really different in different countries as that proportion of what they're seeing of BA2, whether or not it actually causes any changes in their cases. So the colored sort of lines across that are showing in some places it's just remained flat, in some it has gone up a little bit and then decreased, in others it has had some sustained increases, although again, nothing has been a huge surge in these specific countries. There are some other countries not on here that have either much lower vaccination rates or didn't have an Omicron surge that are seeing different impacts of BA2. And then these other kind of bullets are just talking about, you know, there are some European nations where there's already been a peak, but again, it wasn't a huge surge. There are some other places that are starting to see some increases, although again, smaller and gradual so far. Some, there's been just no impact at all. So we're continuing to see low case rates despite that increase in proportion, and so has Canada. Next slide. And then the other news that has been catching some attention recently as well are these BA.1, BA.2 recombinants. So again, these are subvariants of Omicron. They're still in the Omicron family, although there are definitely some genomic epidemiologists that think BA2 should be its own separate letter because it's so different on the genomic epi tree. So again, there have been some recombinations around the world. So one that got a lot of media in the last few days or over the weekend was XE, and that one the UK is showing, and that's the graph on the right here, that they are estimating that the growth rate is even 10% more infectious than BA2. And it's again a recombinant of some mutations that are seen in BA1 and BA2. And BA2 is estimated to be seen anywhere from 30 to 40 or 50% more infectious than the BA1 original Omicron variant. There's another cross recombinant that has been predominant in South Africa now, also in France, with another mutation that had been concerning in some of our prior variants. But again, still very early to draw conclusions about what the impact of that will be. Here in California, we've had at least 8 different kinds of BA2 recombinants, not the XE or this other one in South Africa. In the pangolin lineage, it's called 21K or 21L. Again, very early to tell about transmissibility. There's been no epidemiologic links to any of those except one household cluster that were very clearly in the same household. And we're all still waiting to see more about severity of illness, vaccine immune escape, et cetera. But we are watching all of these things very closely and again, have a great network of genomic epidemiology and whole genome sequencing here in California. Next slide. So one thing that I didn't put a slide on, but what we're watching really closely, actually, even in New York, one of the things they're seeing is as far as their increases in cases, and when you look at their hospitalizations that have started to drift up again, they're definitely seeing an increase in their elderly in the hospital. So it is really important, and there was a recent recommendation updated last week by the FDA and the CDC, and subsequently our Western States Scientific Safety Review Work Group, which Dr. Sawyer is also a member of multiple of those committees, who did endorse a recommendation last week that everybody 50 and over, immunocompromised people 12 and over, and then people who've received J&J can get an additional Pfizer or Moderna booster now available. So that is a new recommendation. This is just some examples of our social media around this. I think this is, again, really important for some of these subgroups that have potentially waning immunity and also at higher risk, again, for hospitalization. Next slide. So shifting gears a bit to therapy and treatment. So want to emphasize to all of you as providers that there is effective treatment for outpatients with mild to moderate COVID-19, and it should be offered to all high-risk patients if they meet criteria. And while certainly a couple months ago even, and even early last month, we felt like we were in a state of scarcity, certainly during the surge, and as these antivirals and other treatments were first being rolled out, we had a lot more demand than supply. But now we actually have a lot more of this available, especially given our low case rates. So if you have patients that are elderly, they have other underlying medical conditions, and we'll talk through that in a moment, really important to offer them treatment and offer it within those first 5 days. The other unfortunate update is that sotrovimab, which is one of the monoclonal antibodies, is no longer authorized, is not effective against BA2, and now that we do have predominance in California as well, it's not being offered in California anymore. And I think the other just bigger picture message on this too is that the monoclonal antibodies are very sensitive to any mutations in the spike protein. And so as we see these evolving variants, often the sort of effectiveness of monoclonal antibodies seems to be relatively short as the virus figures out. The wily virus, as Kim said, outsmarts those, but our antivirals have not been affected by that. So please review product EUAs and NIH treatment guidelines. Clinical guidance is also available around these, especially looking at drug interactions. Next slide. And just another way to frame and think about these outpatient therapies, there's Evusheld, which is a long-acting monoclonal antibody, and that's really for severely immunocompromised people that don't really have a response to vaccination to have that long-acting monoclonal. So that's Evusheld. And then there's intermittently been post-exposure prophylaxis authorizations, but unfortunately the monoclonal antibodies that had been authorized for that are no longer effective against circulating variants. And then again, for others that are mild to moderate illness for treatment, we have one remaining monoclonal antibody and then these 3 antivirals, Paxlovid and Lagevrio or molnupiravir are both PO, and then remdesivir is still IV, but you can give it outpatient as well. Next slide. And then just sort of a nice algorithm. Some of you may have seen this previously, but just to highlight it again on as a clinician, as you're thinking about your patients, if you evaluate them and believe that they are meeting the criteria for patient eligibility, and then you need to think about whether IV or oral. Obviously, oral is often easier to administer. And then there are these Hhs Therapeutics Locators, and there's links on these slides here. And actually, if you click again, this is the kind of, once you get to that website, you can click in sort of your zip code or the patient zip code, and it will give a list of where these different products are available. And it has been relatively staying up to date, I believe. So this is how you as a clinician can help find your patient where to get that drug, and then you can prescribe it and send them to the right pharmacies for that. Next slide, or next, click on this. And there's also a test to treat. This is the federal test to treat program, which is partnering with some pharmacy chains. There are not a huge number yet here in California. These are pharmacies that have a clinician on site that can both prescribe and distribute the medications, but it does help you find out if in your area there are locations that already have this. And we're working really hard, and stay tuned. Hopefully we'll have updates soon on other test to treat models that California is working on. We're really hoping to get some ways that actually at some of, for example, a community testing site would be able to provide medications on site. There are a lot of work behind the scenes that we're working on, so stay tuned on that. But again, you want to get these treatments into people early, within the first 5 days or so after their onset of symptoms. So it's important to get them hooked and connected to care as soon as possible. Next slide. And then this is just mostly, I know Dr. Sawyer will talk a little bit more about MISC. Here's kind of what our epidemic curve here in California has looked like. I believe he'll show you some national data. And after the big surge of Omicron, the black line is overall cases, and then the blue bars are MISC. We did see, and these of course are not exactly proportional, but it's to put them on the same slide. We saw a lot more MISC after the last winter surge versus the Omicron surge, but there is still quite a time delay as well. So often these present 3 to 8 weeks later. So we're continuing to watch this, but I will say we've had over 900 cases here in California, and over half of those patients have been in the intensive care unit, and we've had at least 8 or 9 deaths. So this is not a benign disease, and we do see a fair amount in California. So when people say, is this, and again, you'll hear a lot more about this from Dr. Sawyer, but this is clearly a serious disease that we do see here in California as well. Next slide. Okay, so the last thing I wanted to just end with, and hopefully this will tee up Dr. Sawyer quite well, is our family and kids vaccine campaign. So many of you may know that our overall vaccination rates for 5 to 11-year-olds is actually still quite low. Right now, it's about 1/3 of 5 to 11-year-olds have gotten their primary series or 2 doses. But then if you look at the most healthy zip codes, or what we've been calling the Healthy Places Index quartile 4, compared to our least healthy zip codes, quartile 1, we have a huge gap between those. So over half of the kids in the healthiest zip codes have been vaccinated, and only about 1/5 of them in the lower. So we are really trying to focus on that at the state and working with our local partners to really help close those gaps. And I wanted to share a little bit of some survey data and research that our communications team has heard about what are some of the biggest concerns that parents are giving around why they're not vaccinating their kids. There's a lot of concerns about the long-term risks of vaccine. Because these are newer vaccines, we don't know what we don't know. There's of course a lot of concerns about myocarditis for boys, fertility issues for girls. Many seem to think it'll take 5 to 10 years before we really know a vaccine is safe. So we need to educate them about really when you see these adverse effects, it really happens within the first few weeks of vaccines. There's also the other bucket of area is necessity. Well, COVID-19 is not that serious in kids. Why would I take the risk of vaccine over infection, believing the vaccine might not work, confusion around the vaccine and prior infection, whether or not there's a need if a kid has already been infected to get vaccinated as well for that hybrid immunity. And then of course, there's certainly a set of people whose choices, their decisions are around wanting to have their own choice and not having requirements about vaccine, and that parents know best. So again, you'll get a lot of data from Dr. Sawyer to really back up and be able to respond to the data behind a lot of these concerns, but that's really what parents want to hear, need to hear, and they need to hear from you as primary care providers and healthcare providers. Next slide. So the campaign that we're launching will be starting actually next week and over the next several weeks. We again want families to have a better connection to why vaccines and boosters are important. And just we've seen such a slower uptake in pediatric vaccines right now. Mis and disinformation is so prevalent right now. And then of course, we're all anticipating an approval date for under 5 vaccines soon, and we want to be preparing for that and getting good information out there in advance of that. So we're really hoping to strengthen our collaboration between the state, our local health departments, healthcare providers like yourselves, and then as you can see in our community partnership focus, really working with faith-based communities, after school programs, libraries, First 5, mental health providers, really having an outdoors as we prepare for summer sports and activities in parks and rec. So working on all those partnerships. And I think you as frontline providers, we have a lot of resources that are on these links as far as FAQs, enrollment information. We still need to get more of the smaller clinics to enroll. Some of them still think they need special freezers or other things like that. So we need more frontline providers who are the ones that parents trust to be getting vaccine in their clinics so they can have no missed opportunities. A lot of trainings are available, so click on this link for that. Lots of talking points and toolkits. We're going to have one available tomorrow to really help you. And again, these are kind of the quick and dirty messages, and I'm really excited that we're so lucky to have Dr. Sawyer here today, who again has the breadth of experience which you'll hear about, but can really give you a lot of the actual data that you can feel even more comfortable with these messages that we are providing you. I think that's it. Next slide. So I'll turn it over. Thank you very much.
Amazing. As always, Dr. Pan, just so great to, sort through what we're seeing in the media and hear the truth from the source. And you did tee up Dr. Sawyer beautifully. Before he speaks, I'm going to give a little introduction. There is so much more available if you just search the internet, if you want to find out all the amazing things he does. But briefly, Dr. Mark Sawyer is a professor of clinical pediatrics and a pediatric infectious disease specialist at the UCSD School of Medicine and Rady Children's Hospital, San Diego. He's the medical center of the UCSD San Diego Immunization Partnership, a contract with the San Diego County Health Agency for Health and Human Services to improve immunization delivery in San Diego. He's a past member of the American Academy of Pediatrics Committee on Infectious Diseases, the FDA Vaccines and Related Biological Products Advisory Committee, VRBPAC, in case anybody's wondering, and the CDC Committee on Immunization Practices, ACIP, and is an associate editor of the AAP Red Book. In fact, the VRBPAC liked him so much that he was recalled to work on the FDA approval of COVID vaccines as a temporary voting member, because it's very important work. Dr. Sawyer is also a member of the Western Scientific Safety Review Workshop that has reviewed all COVID vaccine recommendations for the California Department of Public Health. So like so many people in this pandemic, he's been working overtime, and we're grateful to have him here today. Please do submit any clarifying questions you have about this material. We're going to try very hard to answer as many questions as we can at the end. Go ahead, Dr. Sawyer.
Okay, thank you very much for that kind introduction. The most important thing to know about being on VRBPAC, the FDA committee, is the meeting started at 8 a.m. Eastern time, which means tomorrow morning at 5 a.m. I'll be on the phone getting ready to discuss boosters and new variants of COVID vaccines. So look forward to hearing what comes out of that meeting. Today, though, I'm going to give you an update on some recent information that addresses the major questions about COVID and COVID vaccines in children. So if I could have the next slide, this is my version of the major questions. Do children really need COVID vaccines? We hear that a lot in the media and from parents, but we also hear it from some providers. And I think it's important that we get the communication going with providers so that they understand the burden of COVID in pediatrics. We, of course, have the standard questions of whether COVID vaccines work and whether they're safe. And we're all looking for the appropriate communication messaging to get more parents to get their kids immunized, particularly those in underserved populations and those with disparities in immunization coverage rates that Dr. Pan just shared with us. Unfortunately, I do not have a specific answer to your major question, which is probably when are we going to have vaccine for 6 months to 4 years of age? The best I can do with that is my understanding is the clinical trials have completed enrollment and most of the data collection. It's being submitted to FDA. If I had to guess when we're going to actually see an emergency use authorization for 6 months through 4 years, I would say it's probably May of this year. But I've been wrong so many times before that I try not to predict. So we're all going to have to wait to hear the definitive answer to when we're going to have the youngest age group vaccinated. So for today, let's move on to the next slide. And the first question, do children really need COVID vaccines? Next slide shows the data that you've already seen. That is the impact of the surge of Omicron. But this is just in pediatrics. So if you see the darkest line is the younger kids under 6 months of age. Unfortunately, we won't be able to protect them with vaccination. But the next blue line is the surge that we saw in the 6 month through 23 years of age, and the dashed line is 2 through 4 years of age. So Omicron definitely led to a substantial number of kids getting put in the hospital from COVID. So that's one measure that might indicate that pediatric patients need vaccine. Let's move forward to the next slide. And this is a summary that was published in the MMWR just in March of the hospitalization rate. I want to point out a couple of things that can help you address some of the misinformation about COVID in children. First of all, in this particular cohort, 63% of kids had no underlying conditions. So this is an illness that affects healthy children, just as influenza does as well. No doubt if kids have underlying conditions, they're at increased risk, but lots of healthy kids get hospitalized. The majority of them, or at least the biggest percentage of those, are in the very youngest age group, which has immature immune system and developing organ systems, and we see that with many infections. But maybe the most important point of this study is that 85% of these kids were hospitalized because they had COVID. This is not a phenomenon where kids are being put in the hospital for other things and just incidentally have a positive test. So we hear that a lot from some people, including providers, that, oh, well, kids are just getting hospitalized for broken bones and they have a positive test, and they come out in the data as being hospitalized with COVID. In this cohort, 85% were hospitalized because of COVID. And as you've already heard, Omicron was less severe in children, just as it was in adults. We saw a greater proportion of kids getting hospitalized with Delta than with Omicron, but in terms of absolute numbers, we saw many more with Omicron just because it affected so many more kids. Next slide just shows you the fine detail of that study. I'm not going to belabor the point, but again, 85% hospitalized because of COVID, and that did not vary across the age groups. The bottom of the table shows you the symptoms that kids have with COVID. They're very typical of most respiratory infections in children. There's really nothing specific about the presentation in kids. Young kids are not going to be able to tell you whether they have a loss of smell or taste that we use in adults to help to differentiate COVID from other things. Next slide. This shows the cumulative hospitalization by age group. Again, this is all pediatric data over the pandemic. And as you can see, the youngest age group has had the most hospitalizations. The 5 to 11-year-olds are the least hospitalized, and that's a relevant question with regard to vaccination. But the little bracket on the lower right shows you what the typical hospitalization rate is for influenza. So COVID is putting a lot more kids in the hospital than influenza does, and that's a vaccine that we routinely use in children and have used for many, many years. So again, by that metric, it's hard to argue that kids don't need COVID vaccines because so many are put in the hospital with COVID. Next slide. Dr. Pan introduced MIS-C. That's a much more serious problem related to COVID. It's a not completely understood post-infectious inflammatory process with multiple organ systems involved. This is national data on this slide, and what I want to point out is the peak age group for MIS-C is 5 to 11-year-olds. So although they're not hospitalized across the board as often as other age groups in pediatrics, they are the most likely to get MIS-C. So that's very important because nationally, over close to 7,000 cases, 59 deaths. Dr. Pan shared the numbers in California, 900 MIS-C cases and around 10 deaths. So this is a major problem that not only has short-term morbidity and mortality, but long-term morbidity as well. So this is another argument in favor of getting kids immunized. And go to the next slide. We have this curious phenomenon of COVID being associated with increased rates of diabetes. We've seen that in adults, and this is a publication from January of 2022 showing the same thing in children. So the table compares COVID, these are new diagnoses of diabetes and looking at whether kids had COVID infection or did not have COVID infection. And in the right-hand panel, it compares pre-pandemic, before COVID was around, the comparison of kids with or without acute respiratory infection. And as you can clearly see in the highlighted red boxes, the incidence of diabetes in this is two different data sets here, the top and bottom rows in the table. The incidence of diabetes is higher in kids with COVID infection compared to those without. I don't think we completely understand why that's happening, but clearly this phenomenon is holding up over time as we evaluate it. And that's clearly another reason to get kids immunized. And the last thing I'll show on the last slide is that we've all heard about long COVID, protracted symptoms related to COVID infection in adults. Well, this happens in kids too. We're lagging behind the adult community in terms of figuring out what's going on. Is this primarily an immunologic phenomenon, a mental health phenomenon, some combination of both? But kids are getting long COVID too. So there are both short and long-term consequences from COVID with increased hospitalization, increased rates of MIS-C, increased rates of diabetes, increased rates of long COVID. All of this collectively, I hope, makes a compelling argument that kids do need vaccination. If we could move on to the next question, do COVID vaccines work? Of course, that's the next slide. That's a moving target. This is a paper from last week in the New England Journal of Medicine, which got a lot of publicity, mostly negative publicity, with the media reaching the conclusion that COVID vaccines do not work in adolescents in the Omicron era. But actually, the data doesn't say that. And if you read the paper, you'll see that. This is a table showing in the 12 to 18-year-old age group, ICU admissions, critical COVID illness identified as mechanical ventilation and other supportive measures. You can see the overall case numbers and the percentage of cases in the unvaccinated versus the fully vaccinated group. We've seen this over and over again. You're more likely to get in the hospital if you're unvaccinated. You're more likely to have severe disease if you're unvaccinated. And that has held up even in the Omicron era, during which, granted, the vaccines are not as effective as they used to be against previous strains, but they are still preventing severe disease. If you go on to the next slide, it shows the same information for the younger age group, 5 through 11. Here, the differences are not so pronounced, although I'll point out the sample size in the fully vaccinated. Since Omicron has just been around since December, January, and we only started immunizing the younger age group in November, they had very few fully vaccinated kids who ended up in the hospital. But even so, there is differences in severe outcomes for this youngest age group. Next slide. This all translates into these vaccine effectiveness tables shown in adolescents in the top portion, 12 through 18 years of age, and then 5 through 11 in the bottom. They compares the Delta period versus the Omicron period. So this does show the decreased effectiveness against infection in the Omicron variant, down around an overall rate of 40%, with some waning as time from vaccination progresses, 23 to 44 weeks, a little bit lower than 2 to 22 weeks after vaccination. In the youngest age group, again, a decrease in overall effectiveness to around 70%. The next slide shows, however, the same information only for critical illness. So even though the vaccines are not as effective at preventing all illness and symptomatic illness, they are still relatively effective at preventing severe illness measured in this case by critical COVID versus non-critical COVID. So it is not correct to conclude that the vaccines don't work. They don't work as well, and the whole topic of discussion at tomorrow's FDA meeting is, when do we need new variant version vaccines, and how frequently might we need boosters of whatever vaccines we have available? So there will be a lot more information coming out of the FDA meeting. Next slide. It's pretty obvious that if you prevent COVID, you prevent MIS-C, but here's the data that shows the effectiveness of vaccination in preventing MIS-C, and it shows you some of the consequences of MIS-C in the left-hand table, the number of kids in critically ill life support situations with MIS-C. It's a multi-organ disease with cardiac complications, GI complications, neurologic complications. And the right-hand panel shows you the overall vaccine effectiveness at preventing MIS-C. So again, this is one of the severe manifestations of COVID. The vaccines continue to work well to prevent those severe manifestations. So overall, I'm going to conclude that the vaccines do work. Of course, we would all like a vaccine that was back at the 90–95% effectiveness level at preventing all disease, and maybe we will get there with some of the new variant vaccines. But as Dr. Pan pointed out, these variants move so fast. BA2 has taken over the world in just a month, as did Omicron. So it's going to be hard for the manufacturers to keep one step ahead of the virus variants. Let's move on to the next and very important topic, and that is, are the vaccines safe? You know, we have given millions of doses of these vaccines now to children. So parents who are concerned that we haven't studied these vaccines enough, or we don't know enough about them, just need to step back and think how many children have received these vaccines. So we do know what the complications are. And in summary, the only significant complication from COVID vaccines in children is myocarditis. So I'm going to focus on that primarily. But to Dr. Pan's point about long-term consequences, there is no vaccine that we currently use that has long-term side effects. I mean, measured over years. All of the side effects from vaccines are seen with the acute immune response, which happens over weeks following vaccination. And that's true with myocarditis as well. So to frame this conversation about cardiac complications, we have to remember that you get cardiac complications from COVID infection. You get them even more so if you get MIS-C, and you get them from the vaccine. So I want to spend a little time comparing those differences. If you go to the next slide, this is a paper published last Friday in the MMWR, looking specifically at cardiac complications in 3 categories: myocarditis, myocarditis or pericarditis, and finally myocarditis, pericarditis, and MIS-C. It's a little bit of a complicated table, but the comparison here is the rates of myocarditis, pericarditis, and MIS-C in children who had COVID infection, which is the first column of numbers, compared to 4 columns of information about the rate of those complications following vaccination. So the first thing you'll note is that you are much more likely to have cardiac complications from getting COVID infection than you are from any vaccine dose. But in the right-hand panel, I highlighted the worst case scenario, which is second dose. And this is in the adolescent age group, which has the highest incidence of myocarditis of any age. You are still 2 to 5 times more likely to have complications, cardiac complications from infection than you are from vaccine. So it's very clear that the risk-benefit equation favors vaccination. If you go to the next slide, it shows the same information for younger age group, 5 through 11 years of age. They had no cases, 0 cases of myocarditis in this cohort following vaccination, as opposed to a significant number in children with COVID infection. So although they couldn't run the calculations for all of the comparisons, again, you are much more likely to have cardiac complications after infection than you are after vaccination. Not only that, if we go to the next slide, the cardiac involvement in post-vaccination myocarditis is mild. That's shown in the green bar at the top. This is rate of recovery of ejection fraction over time, comparing classic myocarditis, which is myocarditis from other viruses that we are used to seeing over decades, versus MIS-C in the red line, and then following vaccination in the green line. So kids are symptomatic or have measurable decreases in cardiac function for only a few days following vaccination. Most kids recover completely in just a few days. If they're hospitalized, they spend 2 or 3 days in the hospital just to make sure they're not going to progress, and then everything recovers. Of course, we need some long-term follow-up for the impact of either vaccine or infection-induced myocarditis for long-term cardiac function, but the short-term measurements are very favorable. And the next slide is one last thing I'll say about the comparison of risk and benefit. This is shown at the ACIP meeting in February this year. Looking again at the worst case scenario, this is high risk age group 18 through 39 years of age, following the second dose of Moderna vaccine, and it's now clear that Moderna is more likely to cause myocarditis than the Pfizer vaccine. And it shows here in this slide the hospitalizations associated with COVID in the left-hand panel, 2,982 hospitalizations prevented because of vaccination versus cases of myocarditis caused per million doses of vaccine in the right-hand panel. So there's just no comparison. You are much more likely to get in trouble from a cardiac point of view if you get infection than if you get vaccination. So I will stop there and conclude that the vaccines work. Next slide, and the biggest question of all is, are parents going to get their kids immunized? That's up to all of us to communicate effectively. Dr. Pan went through the campaign that the state is organizing to try to help us with that. The major take-home messages are on the next slide. Primary care physicians are the most trusted source of information. That has always been true for vaccination, dating back to the measles hesitant people of the 1990s. That's been well established in the literature. It is important to make sure everybody in your office is on board, or in your clinic is on board with that messaging. Sometimes physician messages get sabotaged by others in their practice who aren't so keen about vaccination. The major overall message is not about preventing transmission in school or helping the community. It's about protecting your family from these severe complications, including your children from complications of COVID. I've already made the argument that the vaccines are both safe and effective. Again, concerns over long-term side effects are misplaced. We just need to keep looking for good, effective messaging to get these points across. Next slide. To help with that, not only is the state doing a lot in this regard, the CDC has a whole resource page, which I did a screenshot of here, for resources to promote COVID vaccine in children. They have social media postings, they have videos, they have information to hand parents, they have talking points for you as a provider to use in your communication. So I encourage you to look at that and maybe tweak your messaging if it's not being effective so far with getting kids immunized. Next slide shows a particularly important issue with regard to COVID vaccine of the youngest age groups. So as Dr. Pan mentioned, we are way behind the curve there with only 20–30% of young kids getting fully immunized. This is a map of San Diego County just showing the variability, and some of this can be translated into the census tract information that she shared with us. But the overall point is that vaccination is different in different communities and the messaging needs to be different, but also the availability of vaccinators needs to be matched with where the greatest need is. So the next slide is information that was discussed almost a year ago at ACIP about the importance of diversifying where people can get immunization. So we're all familiar with the mass vaccination sites that were set up, but we need everyday sites, including primary care provider sites, to get in the game of immunizing young kids. Although the pharmacies have done a great job of immunizing adolescents and adults, they are not so keen to take 6-month-olds into their pharmacy and vaccinate them. So we need private primary care providers to step up and fill that role. In some jurisdictions, school-based vaccination is an option. So I'm encouraging all of you who see kids in your practice at all to consider getting in the vaccine game if you haven't already. Next slide shows some resources to support that effort, again at CDC's webpage. If you go to the next slide, it's a vaccination program provider requirement and support. Again, they'll tell you how do you get vaccine. They'll address any concerns you have about storage and handling of these special vaccines. And I can't stress enough that we need more people to help us get this younger age group immunized. And that's all I have to cover. I'm happy to turn this over and take questions and comments on this material. Thanks very much.
Thank you so much, Dr. Sawyer. Just really wonderful information. And it's just good to see we've had pediatric experts on before, but to see how this information has evolved and to see the data right up to the moment is super helpful as this whole thing evolves. So we have lots of questions today, and I think I'll start just to dive in a little bit deeper, if you don't mind, thinking about, you mentioned that you don't really know about the status of vaccines for under 5s. When are we going to get there? Can you just give us a little color to that? Why is it taking so long, and what's the right process to get there?
Yeah, well, the challenge for the companies are they're matching risk versus benefit. So to avoid fevers and myocarditis and any other complication from vaccine, they've picked lower doses in younger age groups and the lowest doses for the 6 month through 4 years of age group. And based on what we've heard so far, the Pfizer dose that was picked was maybe too low, and it didn't have the same immunologic impact that we were hoping it would have. There wasn't a concern about side effects, but there was a concern about effectiveness. So they end up going to a third dose, and it's why it took additional time to gather the data with a third dose. Moderna just recently, a week or two ago, released to the media anyway, their preliminary data with a 2-dose, also lower dose than older kids and adults. And that sounded encouraging. So it's a matter of getting the data that we've got the right dose that balances immune response with side effects. And so I'm hoping that we've gotten there, at least with 3 doses of Pfizer and 2 doses of Moderna at the current dosing.
Okay, great. That's really helpful to hear. Erica, maybe I'll pivot to you and talk about schools for a minute. My understanding, and I might be wrong, is that there's perhaps a school vaccine mandate in the fall, or there at least have been conversation about that. And so with only 30% of these kind of school-age kids vaccinated, how should we think about this from a statewide and a policy decision? And then just to follow up that, I saw that slide about innovative ways and places to vaccinate kids, and are there plans to do school-based vaccine clinics or really penetrate where the children are this summer?
Sure. I'll answer those in reverse order. There have been a lot of local and state and other efforts around not only school-based vaccine sites, but now in preparation for that under 5, really starting to work with larger childcare kind of providers and regional centers to try to have some community vaccination sites where we can get those younger kids, but also continue to try to get those other family members that may not be vaccinated yet. So there's a lot of efforts underway for that, and really with a focus to Dr. Sawyer's point on where are those areas that we think we have either less providers that are enrolled or just less access, so that we can really bring vaccines to where people are and have access not be the barrier. So lots of efforts on that are underway. I think the requirement conversation, so essentially what we and the administration announced last fall is that once the FDA fully licenses certain age groups, then that is when we would kick in the emergency regulations for K through, well, so it'd probably be, we're waiting for 12 to 15-year-olds, right? And actually that's another crystal ball question. We're wondering when that will be licensed. We are hoping very soon. And actually, I might ask Dr. Sawyer offline about that, or we could ask him now. But so once 12 to 15-year-olds are vaccinated, as many of you may know, if you have either children or you're a pediatrician, the entry points that we typically have for school entry are either childcare or kindergarten or 7th grade. So there are 7th grade vaccine requirements. We would once 12 to 15-year-olds are fully licensed for vaccination, then we would start requiring from 7th grade up, 7th through 12th. So that first year we would be requiring all of those. So if that all happens, it will need to happen on the sooner side, then it would be effective on July 1st. And then there's a lot of conversations, there was information originally saying that we would, if it was approved, say, later in the year, that the next effective date would be January 1st. There's a lot of concerns right now about mid-year implementation. So I think a lot of conversation happening about all of that as well. So that's sort of where we are. And then, to your question, I do think we really have so much room to go on our 5 to 11-year-olds as far as those younger grades. So hope that we can get there actually sooner, just on getting that good information out and access and trust. But I think, it may take a requirement to really get us to where we need to be in that age group.
I I would like to comment on the older age group, the 12 through 15, and the lack thereof of a full FDA approval so far. It is a great illustration of how careful and deliberate FDA is being about full licensure. You know, early on in the pandemic, people were concerned that FDA was rushing the process and taking corners, and this clearly shows that they're not. They are carefully reviewing the side effect profile in the 12 through 15 year of age group. They do get myocarditis, although, as I've said, at a much lower rate than after infection. And they're making sure they have all that information carefully identified and you know, can support a full approval. I also don't know when that's going to happen, but I know that data has been reviewed for some time, so I am optimistic that it will happen in the relatively near future.
Thank you.
So great to have you here, both of you. So after that, and then I'll lean into Dr. Sawyer for a minute for a few questions, but Erica, one more question about schools. Now that kids are unmasked in schools in many parts of the state, how are we doing? What are the volumes of outbreaks and school closures that we're seeing now?
Yeah, I don't have any hard data to share with you today, but I did show you the overall case rates in general. And there is still quite a bit of school testing. Actually, that has not slowed down yet. Thankfully, so far, you know, again, I think the rate of decrease has started to plateau, and we might see, I think there's a lot to be expected for some, you know, either plateauing and or smaller increases with relaxing, not just in schools, but everywhere. People are just, you know, there are a lot less mitigation measures happening. And BA2 is more infectious, as we were discussing. So I think there are some overall minor increases, but overall, as you saw from all the curves I showed, we're thankfully still seeing decreases or plateauing. Yeah.
Great. So Dr. Sawyer, leaning into this sort of, what are the communication strategies that we use to talk to families? You know, I heard in your messages what we've used as pediatricians for a long time. We are partnering in protecting your child and family, and we're on the same page there. Vaccines are safe, vaccines are effective. Those are the three key messages. Are there any flavors that you would add to that in particular communities, or answers to some of the questions on Erica's slide about maybe you want to address? How would you talk to a family about concerns about a girl's future fertility?
Yeah, you know, it's a great question and a very long and complicated set of answers. One thing is that although primary care providers are the most trusted source of information, occasionally you need supplemental messengers from the community that you're trying to reach out to. And that's why the state program is so great, that they're involving people from the faith community and other community organizations. The bottom line is you have to have trust established. And if it's not established with the mainline medical community, we need to reach out to other partners to make sure we establish that trust. For some people, the science establishes the trust, that we've looked at this, we've looked at it carefully, here's the data. But for others, that doesn't work, and you have to appeal to, as you said, we're here in a partnership. I want the best thing for your child, just like you do. Here's why I think this is the best thing. I don't want to minimize the complexity of trying to do that, and that it doesn't work for some people, and it probably will never work for some people. But I do think we can combat some of the main misinformation pieces, and fertility is one of them. There has been zero evidence, and this has been discussed at the FDA meetings. There has been zero evidence of any fertility problem around the world in which billions, billions of doses of various COVID vaccines have been given. So that is complete misinformation. Myocarditis is not misinformation, but the rates of myocarditis are important, as I've made a lot of points about during this talk. So and that's a partial answer. I don't have a full answer to your question.
Yeah, it's very helpful. What about plans for a booster in kids? You know, some of the kids are coming into that window where maybe the immunity is waning, as we hear about in adults. Is the FDA talking about that?
Yeah, that's a major part of tomorrow's discussion, is when do we need boosters and for whom? Now, As Dr. Pan pointed out, the recommendation was just issued last week for those 50 and above. Not everyone agreed with that. Some thought it should only be 65 and above, the highest risk age group for COVID. And again, that's the question. It's risk versus benefit. So when we get down into young children who are overall at less risk from COVID, and if the vaccines are still preventing the serious side effects of COVID infection, then you could argue they do not need a booster yet, and we should wait either until we have a new variant version vaccine or until at least a longer period of time has passed and the residual immunity from vaccine, if it continues to wane, puts kids at risk once again. So it's a really complicated formula, but the bottom line is risk versus benefit. The highest risk group, that's easy to come up with an answer. For lower risk groups like healthy children, it's harder to come up with an answer.
Yeah, helpful. One more vaccine question, then I have a question about treatment. People are always asking the question of how long after a case of COVID should my grown-up or kid get vaccinated. The question today was specifically about children. If you want to comment on that about anybody and about kids specifically.
Yeah, the official standard answer from CDC is you can get immunized at any time interval after you've had COVID. And to some extent, that depends a little on where we are as a community with outbreaks and variants. It's clear that natural immunity itself is not sufficient to protect you completely. You can get reinfected. So if BA2 starts taking off and causing more severe disease, then we're going to push up the time for a booster up to immediately after you've had COVID. If things stay quiet, then, you know, the original recommendation was to wait at least 90 days. So you can sort of finesse that depending on the risk of your patient sitting in front of you, depending on the outbreak situation in your community. But the official guidance is you can give it any time you want.
Wonderful. That's both really clear and also gives people a reason to think about it. So thank you for that. What about treatments for COVID-19 in children? How do you, are any of these therapeutics available for children? Are they being used?
Yeah, we are really restricted. All the monoclonal antibodies are only recommended at age 12 and older. So we have nothing except remdesivir for the younger age group at the moment that's FDA approved. So I should have made that point. That's yet another argument for vaccinating young children, is because we don't have any of these other tools at our disposal to prevent or mitigate infection once it happens.
That's really helpful. Erica, someone was just asking about testing and with these new variants. Is our testing still working for new variants?
It is. I actually just saw a presentation from the FDA yesterday or the day before, and they are on an ongoing basis kind of looking at the various antigen manufacturers, and currently the validity is still good. I mean, I think there was some minor decrease between Delta and Omicron, but in general, the testing is still effective. And, you know, there's obviously still a range of sensitivity and specificity, and all, of course, like everything else, depends on pretest probability. But overall, the testing is holding up with these different variants so far.
Okay, great. Lots of questions and not enough time, but I do want to end with a question for you, Dr. Sawyer. People wonder about how you counsel people, and particularly children, but really anyone with varying levels of immunosuppression. So, for example, if you have a teen with mild IgA deficiency, is COVID going to be much worse for them, or sort of how do you think about the spectrum of immunodeficiency and COVID risk?
Yeah, well, it is a spectrum, and that's why it's challenging to answer that. The more immunosuppressed, clearly, the higher the risk, and we're seeing that particularly in transplant patients who are probably the highest overall risk. And for them, you know, we're hopeful that monoclonals will soon be available for younger kids who are transplant recipients. And or that's a group for whom boosters are easy. It's easy to make a case for boosters in that high risk group. The milder your immunosuppression, so we have so many biologics that are being used for rheumatologic disease, for inflammatory bowel disease, for all kinds of things. It's really hard to parse that out by each disease. I think my sort of default is, when in doubt, give another dose of vaccine. We are not seeing higher rates of complications, particularly myocarditis, with booster doses. So at this point, the second dose is the most likely to be associated with myocarditis. After that, the third dose and the fourth dose are less likely to have those complications. And we do know that they boost antibody levels and do help with protection, particularly against the variants that have deviated from the original vaccine strain.
Oops. Okay, wonderful. Well, unfortunately, we're out of time, and that's all the time we have today for questions and everything. And I really want to thank you both, Erica and Mark, for presenting today's content. Thanks for everyone for listening in. Just as a reminder, our next session will be Tuesday, May 10th. You can always go to our website at covidroundca.com. And a final reminder, I just want to say out loud that our slides are available as a PDF with all of that information about where to get therapeutics, all of the links that these speakers have had. You can get those and send them out to colleagues who have questions. And finally, just remember, if you want CME to do your survey, that you'll get around 5 p.m. today, and you'll get your CME certificates in about a week. Thank you, everyone. Hope to see you again, and have a great day.
Thank you. Take care.